Welcome, everybody. My name is Will Fenton. I am the Director of Research and Public Programs here at the Library Company of Philadelphia. I suspect that many of you have attended previous sessions, so you already know my spiel, but I'm going to repeat it just for anybody who's new. Library Company, we were the first subscription library of America, founded by Benjamin Franklin in 1731. We have changed a lot since then. Now we are a research library, and we have these great program areas in early American literature, history, and culture. We have a women's history program that's fantastic, graphic arts program, also fantastic, a program in political economy. And then honestly, I think our crown jewel is really our program in African American history, our endowed program, which is led by Deirdre Cooper Owens, who you saw in the first session. If you happen to miss that, we've put it up on our YouTube channel so that you can listen to that wonderful roundtable conversation. This is part of our seminar series, which we have necessarily moved online. This isn't normally the way that we do them. I was complaining to Sam before we kicked off about how I'd much rather be doing this in our reading room with our collection materials, with all of you in person. But one thing that's nice about doing it this way is that we certainly have a lot more capacity. We can reach folks that don't live in Philadelphia or can't make it into the library company. And we can offer these sessions for free, which is also a nice thing for everybody who wants to keep learning over their summer break. This is a first also in the sense that it is done in conjunction with our Mellon Scholars program. So you'll see that we have Gigi up on screen, giving us a nice wave. She was one of our Mellon Scholars. We're also joined by Rick Mizell, another one of our presenters, and participated in the Mellon Scholars program. So I'm just delighted that we've sort of kept a cohort despite the fact that all of this is unfolding through Zoom. Today, we're passing it over for our third session to Dr. Samuel Kelton Roberts, Jr., who is Associate Professor of History, Socio-Medical Sciences, and African American Studies at Columbia University, where he was also the former director of Columbia's Institute for Research in African American Studies. Dr. Roberts is co-founder of the National Black Harm Reduction Network and serves on the boards of Alliance of Families for Justice and the Legal Action Committee. Busy guy. In 2013-2014, Dr. Roberts served as the policy director of Columbia University's Justice Initiative, where he coordinated efforts of several partners to bring attention to the issue of aging and the growing incarcerated elderly population. He also served as the policy director of Columbia's newly inaugurated Justice Initiative, now the Columbia University Center for Justice, and he was the editor of the center's first research publication, Aging in Prison, Reducing Elder Incarceration and Promoting Public Safety. That's from 2015. At Columbia University, Dr. Roberts leads the research cluster for historical study of race, inequality, and health. He is also the host of the Public Health and Justice podcast. He's a podcaster, and you'll be able to pick that up from his wonderful audio equipment. I sound tinny in comparison. The podcast is PIDIS, People Doing Interesting Stuff. I love that title. And he's currently writing a book tentatively entitled To Enter a Society Which Doesn't Want Them, Race, Recovery, and America's Misadventures in Drug Policy. Thank you so much for being here, Sam.
Thank you so much, Will. And thank you to Deirdre Cooper Owens, the director of the program. Thank you to the Mellon Fellows for joining us and anyone else who might be out there watching this. I will try to do my best here. Will and I were talking before we started broadcasting that I'm still more used to speaking with live audiences than I am with Zoom audiences. So I will try my best to equip myself properly. Starting with, I need to share screen, right, Will? Yes.
That's right. And just a quick note while we're getting the screen share set up, and it looks gorgeous, by the way. If, as you're listening to this presentation, you have questions, we have a Q&A button at the bottom of your screen. I encourage you to log those questions as you think of them, because if you're anything like me, it'll just dissipate as you're letting all of this, wonderful seminar wash over you.
All right, thank you. So, when I was invited to join you all for this evening, I was asked to speak a bit about thinking about this current pandemic moment in some historical context. I'm certainly not the first to say that what we're experiencing right now is in many ways unprecedented, but it certainly does not go without certain historical antecedents and ways in which we've seen particular histories unfold that certainly in ways presage what we're seeing now, and possibly even offer some lessons to be learned. I'm not one of those people who necessarily thinks that history is there just for the utility of telling us about our present or our future, but I think this might be one case in which I hope, this is my modest offering, to how we might think about race, political economy, and infection in the 21st century by going back to the late 19th and early 21st or early 20th century. Shameless plug, as Will mentioned, I am the host of a public health and justice podcast, People Doing Interesting Stuff. I've let that go dormant in favor of embarking on this other one for 2020, which is Black Lives in the Era of COVID-19, of which I'm the co-host with my good colleague Mabel Wilson. And all that is pretty much should be on any podcast platform that you may use. We've had some really great interviews with people really about doing work and living in the midst of a pandemic and while being Black, of course. All right. So just to start off with, there's going to be a few main ideas. First, there's a historical paradox between the progressive era versus the nadir of race relations. This I will explicate a bit further. I want to talk about the health effects of segregation and the political economy of health and illness, the social, political, geographic, and scientific constructions of race, and racial, social, scientific, and geographic constructions of disease. I want to talk about the reactionary, but also the liberal uses of social stigma and the politics of infectious fear. Then also the possibly inherent limitations of public health under liberal capitalism, which one of its instances I call racial utilitarianism. So particularly for the Mellon Fellows, but maybe perhaps many in the wider audience, you might have a sense of what the progressive era was between roughly 1890, 1920. That periodization certainly is flexible depending on the historian you query, but it really is hallmarked by a few kind of signal events. One is the expansion of democratic participation, particularly the suffrage with women, attacks on political corruption and machine politics. We here see the beginnings of the expansion of our welfare state and social provision, presaging what we see in the New Deal. The increase of state intervention and regulation in markets, food and drugs, the economy and social welfare, public education, and pragmatic / utilitarian social philosophy is one. Bureaucratic aggrandizement, which is to say state, corporate, and organizational entities which actually accumulate for themselves increasing power in the name of the public good. Scientific management, particularly Taylorism, I think many of us would be critics of that movement. And then municipal public health, particularly in bacteriology after 1880, modern sewerage and social hygiene, surveillance, disease reporting, vital stats, and Foucauldian governmentality, tenement reform, etc. And then what many of you may not know is that at the same time, we had what other historians have called the nadir of race relations, which is more or less coterminous and simultaneous with the progressive era. And that is a period of disfranchisement through poll taxes, grandfather clauses, white primaries, literacy understanding tests, et cetera, as a means of conducting quote unquote reformed, rational, or legitimate politics, literally disenfranchising Black Americans on the idea of having our electoral system more efficient and legitimate. This was a period of intense race pogroms, also known as race riots. Lynching emerged particularly strong during this period. The cultural assault on Black bodies, particularly in the modern popular media. Eugenics as a means of improving the social body and the body politic. And then also the entrenchment and modernization of residential and other forms of segregation and Jim Crow politics and culture. All of this is part of this same time period. So one of the informing and motivating questions for the work that's represented in this talk is, how could we have both of these things? When I was in high school and college, we were taught about all the great benefits of the progressive era. And then, reading on the side or taking classes in African American history, I learned about the horrors of this period. And so there is a paradox here. And so one way of exploring this is through a consideration of the health effects of residential segregation, by which we might think of it as being residential segregation as one of many modes of racial capitalism, which is a term I take from the political theorist, the late Cedric Robinson. If residential segregation is an expression of a certain, which is to say, historical form of capitalism, then it, like capitalism in the abstract, has its own spatial articulations, which is to say, that's a really fancy way of filling up a slide on PowerPoint, of saying that capital has its own way of arranging space, be it in tenements, be it in large office parks, be it in how we do our how we site locally unwanted land uses, such as incinerators, et cetera, et cetera. All this goes by a logic of capital. It need not be this way, but that's how it has been certainly for the past 150 or more years. Simply, though not exhaustively put, the health effects of segregation might refer to the differentials in health outcomes experienced by populations by virtue of their social, economic, and geographic experiences of racial ascription. Being Black in this country, being Latinx in this country, or being, inhabiting white bodies in this country, is in fact always mediated spatially through this logic of capital and of racialization combined, making racial capitalism. Inevitably, all of this is bound up within the urban political economy of race and health, with its attendant connections to systems of gender, space, labor, and class. Many of my colleagues in epidemiology, in other social sciences, have theorized this. And this is one from Schultz, Williams, Israel, and Lempert from about 15 or so years, actually almost 20 years ago. But this more or less is representative of many of the schematics you might see drawn between fundamental, indeterminate, proximate, and then health outcomes themselves. Thinking about it as a kind of four-tiered way of thinking about the pathways to what we call health disparities, or what I prefer to call health inequities. They may go from the macro social, including residential segregation, all the way down to the proximate, meaning your physical, actual, your embodied lived experience in terms of stressors. That could be financial insecurity. This schematic has ineffective police response. I think the authors writing some 20 years ago, if revisiting this today, would probably say not just ineffective police response, but violent and murderous police response. Health-related behaviors certainly are mediated by the social environment as well. It goes on and on and on. And here we see, taking from that, moving to a more longitudinal, shall we say, or maybe a longue durée view of health outcomes and the health effects of segregation. Here is a very grainy, pixelated, and I'm sorry if maybe nearly illegible graph, but you can see the general outline of 4 demographic groups and the decline of mortality in the first half of the 20th century. The uppermost ones are non-white men and women. The bottommost are white men and women. You see they all decline largely because of improvements in sanitary services. Keep in mind that the antimicrobial revolution is really about 1950. It starts around early 40s or so, but it really kicks in on a public health level after 1950. So all of these improvements that you see here aren't because we got vaccines necessarily, or aren't because, that our medical treatments were so widely available and so effective that we were treating people on a mass basis. We just started installing sewerage systems, getting clean food and milk to people, et cetera, et cetera. The benefits, however, as you see in this graph, were unequally realized. Some of the wages of residential segregation might include non-infectious conditions such as injuries, nutritional deficiencies. The psychological is something that we really started to visit after about the 1960s and certainly continuing now. But then prior to the antimicrobial revolution, whooping cough, pneumonia, typhoid, gastrointestinal infections, and the big one, of course, is tuberculosis. I want to say now, I'll come back to this, that the antimicrobial, shall we say, maybe the reign or our vanquishment of the germ was really but a short 30 years. Coming with the advent of HIV/AIDS, we were once again reminded that we live under the caprice and vicissitudes of viral transmission. And I won't say too much more about that because I want to revisit it at the end. But still, it had a profound impact on how we think about our society and also how we think about history. Here is just a kind of brief table showing the top causes of death among non-whites between 1910 and 1940. I don't know if you all can see my cursor here that I'm circling around, but you see here in 1910, TB and pneumonia 1 and 2, also in 1920, they're 2 and 4 in 1930, followed closely by syphilis as number 8. 1940, TB is still the second, pneumonia is number 5. Even before the post-1940s antimicrobial revolution, Black longevity was improving, as I said, as was white, undoubtedly due to improvements in conditions of living. But these wide disparities in health outcomes persisted, largely because of their different social, economic, political, and legal positions. Here we see estimated average length of life from 1900 to 1950. We see an appreciable incline. 59.2 years by 1950 for non-white men, 63.2 for non-white female, beginning at roughly 32 and a half at the beginning. That's an appreciable increase by 1950 here. Much more, of course, because white started better and also ended better here, even though we start to see a closer rapprochement, shall we say, between all 4 demographic groups here. And then we see age-adjusted death rates on the decline through more or less the same period. So why study TB? And I would say, statistically speaking, few early 20th century, late 19th, early 20th century conditions were as well defined by socioeconomic class, which is itself a function of racial capitalism. And I want to be clear here, we could talk about more of this in the Q&A perhaps, that I want to offer the modest suggestion that racism is not solely, not only, but certainly in large part defined by the system of relations of production. It is a really good way of rationalizing capitalism itself, having regimes of racial segregation. Just like the construct of race itself often has served to that system. It's not exclusively for that reason alone. There's been debates going back for at least 2 or 3 generations, but I think all would admit that it certainly has a large role in capitalism in North America, in the United States. Well, actually all of the Americas, really. I mean, that's how the Americas were founded on racial capitalism, right? So tuberculosis history in most Western settings, therefore provides a good lens for an examination of modern political economy, racial capital, and statecraft through public health. And taking such a large toll in health and life among whites and blacks alike, TB was demographically important. And at the same time, because of its etiology and pathology, it remained so mysterious throughout much of the early 20th century. It easily lent itself to stigma and fear, much as HIV/AIDS had in the 1980s, 90s, and really, I mean, in a lot of ways till today, even though I would say certainly less so than 30 years ago. So let's talk a bit about the political economy of health and illness, and constructions of race and constructions of disease. The main idea here is that at the turn of the 20th century, meaning from the period that I described at the beginning, let's just say 1870 to 1920 or so. That could be expanded out a bit, could be narrowed a bit, depending on the area you're talking about. The main idea here is that people arriving to the cities here in the United States were not merely passive bodies in a system of public health. By their mere presence, they influenced policy and politics. And further, they were also political beings and therefore participated in the public sphere in ways which redounded to many aspects of urban politics itself. And I'll expand that out a bit as we go. Individuals, researchers, social scientists, such as Thomas Jesse Jones, noted that the peak between 1878 and 1886 of tuberculosis amongst African Americans, but also with whites too, reflected the beginning of large-scale migration to cities after the failure of Reconstruction. And this marks the beginning in most southern cities of de facto residential segregation and declining environmental conditions for Blacks. So you have thousands of people, even before the Great Migration, moving to cities in the South. And they're all competing for housing, for jobs, for resources, and it takes its toll. And what happens is that one of the indicators of this is in fact an increase in tuberculosis. This is at a time when many, particularly white statisticians, would have claimed that African Americans and others died of TB because they were really from an inferior race. That's a longer history that we could talk more about. It certainly dovetails later with the eugenics movement, but in a lot of ways prefigures that as well, and goes back to kind of even Enlightenment era mythologies of noble savages and nature versus civilization, et cetera, et cetera. Black social scientists such as Thomas Jesse Jones, but more prominently Du Bois and Kelly Miller, were all part of this intellectual movement to actually counter these mythologies with real science, with real statistics. At the same time, at what we will, let's just call it for now, for our purposes, maybe perhaps counter-historically, there were grassroots movements, which, or popular movements, shall we say, whose purpose was to popularize the gospel of health. These could be found in uplift movements, embedded within uplift movements, as has been, chronicled by, scholars such as, Darlene Clark Hine, Kevin Gaines. The list goes on and on and on. Michelle Mitchell for another. We typically give credit for this movement, the National Negro Health Week movement. We give credit to Booker T. Washington in ways that are deserved, but maybe not so. The germinal genesis of these were actually more local and, like I said, grassroots, but he actually had this vision of making it to a national movement, which began the year he died in 1915. It began fairly conservatively in ways that, for which Booker T. Washington was famous in his own brand of racial conservatism. But by the 1930s and certainly into the 50s, it takes on a more urgent call for health equity. African American Health Organization politics included the Atlanta University Conference meetings, after the first two of which were headed by Du Bois and often treated health issues and topics. Women's clubs in particular were very vocal, particularly in mobilizing Black communities and also being public at the forefront of health organization. The Black independent hospital and nursing school movement, again chronicled by Darlene Clark Hine and others, and neighborhood cleanup drives. Health was a register in which Black uplift politics was conducted. That's really important because this occurred in ways that we did not see in the last 30 years, since the late 20th century and now, right? Today, because of COVID-19 and because of HIV/AIDS, we see more of that. But for a long period, we forgot how important health was as a vehicle or as a language through which one can make claims as citizens. And certainly this was in robust evidence during this period. There was, as I alluded a few moments ago, a theory that African Americans would actually become extinct because of their freedom from slavery and their contact with quote unquote civilization. Just to give you a thumbnail sketch of this, the theory was that the best place for Black people was slavery. There, they lived carefree lives, rent was paid for, they were well fed, they were clothed, and they got a lot of good outdoor living, shall we say. As you might imagine, this was a line espoused by many people who were members of the former Confederacy or certainly sympathetic to it. Many of the people who were either now featured in places such as Monument Avenue in Richmond, Virginia, which looks a lot different these days if you haven't seen it, or people who revered those gentlemen as being, particularly prescient or racial issues. Again, it was left to African-American social scientists, some of whom I mentioned here, Du Bois and Miller, Thomas Jesse Jones, and many others, to actually muster real statistics to counter this. And it was a pitched battle, by the way. You had people like, there was a statistician, a white man by the name of Frederick Hoffman, who had I think it was like a 300-page volume, basically proving that Black people would go extinct. And Du Bois, in ways that really, the ways for which Du Bois is classically famous for his insightful intellect and his incisive and scathing critiques, tore it to shreds and showed it to be shot through with methodological errors, political assumptions, and at the very least racist undertones. Not for nothing, Du Bois was trained at the University of Berlin, which was recognized as the home of modern social science investigation. So when he comes back to America, he's quite literally perhaps the most well-trained sociologist in the country. Equipped to take on any of these racist, quote unquote, scholars. And it's a pitched battle that, he and others waged for a solid 20 or 30 decades. 20 or 30 years, rather, 2 to 3 decades. So I want to talk a bit about the first 2 parts of my talk, as you might imagine, have some resonance with the current moment. There is at the moment, not necessarily dominant discussion, but one that I find a little bit scary for want of better words, discourse about the genetic susceptibility of certain populations to COVID-19. Completely in ignorance of the social conditions in which people live. We live in an era where we're still, blaming people for their disease, be it COVID-19 or HIV or, non-infectious conditions such as substance abuse or diabetes, you name it. That's still with us. Certainly very robustly so some 100-odd years ago. It's still with us today. What I think comes closer to home is what I want to talk about in the next, for the remainder of my time here, which is really about stigma and how we think about the geography of race and disease. All right. So this might get a little bit in the weeds here in terms of where I'm going to take us, but I want you to follow me if you can. This would be the point where I would ask you to, if we were all sitting together live if we were filming before a live studio audience, as they used to say, I would ask you, just please raise your hand if there's something you're not following. But right now, I guess I'm just going to have to trust that I'm doing well to get my message across here. So here we go. Back to TB. What we find with the bacteriological revolution of the 1880s is that TB is actually a disease that's passed around by transmission. Prior to that, it was often supposed that it was something that you just got from bad air, like, what they called, like a kind of just like foul airs that emanated from the ground or from your own faulty constitution, i.e. your biological racial, what later would be called genetic heritage. And in fact, what we found in the early 1880s is that it's transmittable. It's a bacillus, a bacteria. This had profound implications for how we do public health in a couple of ways. One is that now the emphasis of prevention becomes stopping the bacteria. Particularly one of the more compelling and still useful theories about that was the theory of house infection, which simply put is that the closer you live with people who have tuberculosis, the more likely you are to get it. I know that sounds really simple today. I mean, after all, it's that theory which has motivated our current invocations to, wear a mask and stay 6 feet apart, right? This is, but at the time it was rather revolutionary. It should have, by logic, it should have really all but banished the idea of racial predisposition. right? If it's a bacteria, then that's pretty much all she wrote. But instead, what happened was an intellectual compromise by which you had people saying, well, maybe yes, yeah, maybe it is transmissible. Maybe TB is infectious. But what if African Americans are actually just biologically more susceptible to it? So race isn't completely taken out of it, or isn't entirely the factor of developing the disease, but it's not entirely removed either. And so house infection, which should have putatively, or at least one would hope, be what we might call race blind, race neutral, deracinated. Actually, that's not the case at all. And here you see some clips, newspaper clippings from the early 20th century, which talk about infected Negroes who are a source of consumption and also are dying fast, right? So now the fear becomes that African Americans, yes, they are dying because of house infection, but also because of their inability, possibly their biological heritage, and then also their inability to prevent infection. If this sounds somewhat, resonant, or if it reminds you of what we're seeing today with COVID-19, that is not, you're not alone. We see a lot of this where we're, blame people for their infection. We don't pay attention to the structure of inequality that has produced that infection. All right, let's, in just a moment, please. As a result, let's take one city, Baltimore, which in a lot of ways is like Philadelphia. And I know that my principal audience here, the Mellon scholars, in a better world, in a pre-pandemic world, you would be all in Philadelphia. We would all be in Philadelphia right now speaking with each other, but we're not. But since you are fellows of the Philadelphia Library Company, I will also bring about some of the events that happen in Philadelphia and in Baltimore as well. Baltimore is the first city in the United States to actually pass what today is kind of foundational legislation for doing public health, which is to say mandatory reporting of a disease, right? If you're at all curious about, say, today's controversies about testing, the current president, literally told a large audience that he had told his people to stop testing because when you test, that means your numbers go up. That's because we have laws that say when you test, you must report. And it's really not effective to say, well, let's just stop testing. Testing must happen. I think probably everyone watching this knows that. Unfortunately, people in the White House do not know that. This was not the way we did public health necessarily before 1875. Certainly when that's our first reporting legislation is passed. The first TB reporting legislation is around 1896. And that too should have been racially neutral. It should have been where everyone who's got it, we report, we do contact tracing, we find out how we got it, and then, think about what does this tell us about poor housing, about poor labor conditions, about inability to find nutritious food, about people who may not know how to prevent transmission, for example. What ended up, just like much in the way that house infection ended up with an intellectual compromise, we ended up with a policy compromise in Baltimore, but also in Philadelphia, which soon after passed similar legislation. And, by like 1907, 1910, I think about 80 odd cities over a population of 48,000 had passed this type of reporting legislation, which is basically say every real city, every major city in the country. And the compromise went like this, that if you were poor, you lived in a tenement or an alley house, poor habitations typically in which you would find poor people, reporting was mandatory. If you lived in better housing, it wasn't necessarily that mandatory. And if you were under the care of a private physician, reporting only happened if the physician deemed it should happen. So what ended up happening is that you had a loophole. TB was a very stigmatized disease in a lot of ways, like the way HIV was in 1980s. And so many people with means would prefer that no one know that they had it. And so they could escape that. Whereas the poor were put in massive drag nets of, people knocking on their door saying, we want to test your spit, your sputum, and see if you have it. So then, even then, at the outset of one of some of these germinal moments, these foundational moments for modern American public health. It's already baked in. Racism is already baked in there. So I just want to be clear. If anytime you have someone who says, public health has been doing a great job, but sometimes racism shows up. Yeah, but also it was baked in at the very beginning that we've always been doing it that way. Here is an article enjoining readers, white readers, of course, to be afraid of African-American domestic servants, women in particular. And this one says 4 generations of consumptives who couldn't be taught about the use of any precautions at all. Basically, these women they're ignorant Black women who are completely uneducable about how to prevent the spread. Notice 4 generations, one of whom is clearly a toddler, who you might imagine is fairly uneducable about a lot of things. At the age, I would have guessed that this child might be no more than about 12 months. So, they're not learning a whole lot, let alone about the complexities of infection. There's also a cat here, which led me to believe that this picture is actually a portrait. These women probably didn't even know what they thought they were posing for a classic kind of turn of the century portrait. They didn't know that they're going to be used for the uses of stigma, that their image would literally be used against them. They are wordless because they're not interviewed here, and now even their own image is out of their control. This is another image from a similar article where they were shown, these are houses where laundry work is done. The idea being that people would send out their laundry and then Black women would pick it up every week and bring it back a few days later clean. They didn't have automatic washing machines the way we do now, or necessarily a laundromat. And so the fear here is that you send your laundry out, visibly dirty, it comes back visibly clean, but it's actually microbially contaminated. So you need to be very scared of the Black women in your employ. And so this led to a geographic discourse about lung blocks. In essence, where do we find the hot spots? If you're seeing here a resonance between this and today's moment of COVID-19, again, that is not by accident or coincidence. You might have heard particularly how we focused on Elmhurst, Queens in the early outbreak here as being a quote unquote hotspot for the pandemic. And really it was just about, why are things so bad there? And we really did not do much to think about what were the structural inequities that produced that. Elmhurst is an area that has a higher than average level of really people living below the poverty line. Housing, residential crowding is an issue there. A lot of the people who are employed there work as what we would later call essential workers, meaning they had to go out to work. And so they were serially exposed a lot and then exposed their family. That's how we got Elmhurst and the tragic, ironically named another neighborhood in Queens called Corona Queens, which, years after it was named that, became known for the coronavirus. Here we see, this is a lung block here, which is a largely African-American neighborhood. I see oh, here we go. There's my animations there. So this area here is a largely Black, well, almost exclusively Black neighborhood that's segregated. This is the hot spot of Baltimore. This is another drawing here from a social survey of the same thing, surveying housing conditions. The recommendations of this housing survey actually recommended no real amelioration of Black housing. They said for white occupied tenement housing, yes, something should be done. But when it came to Black housing, their recommendations that you should just train Black people not to spread the disease and to live better. So again, that blind spot and that blithe ignorance and willful ignorance of what was just patently obvious to anyone who would, apply their own sense of logic and investigation. Lung blocks showed up everywhere. Baltimore's was the first, but every city all of a sudden said, hey, that's interesting. Let's find our own lung block. And so non-white neighborhoods all over the country. In San Francisco, it was Chinatown. In New York, it was the Irish and the Chinese. Keep in mind, the Irish are not yet white in this period. Throughout the South, Black lung blocks were everywhere. It becomes a geographic sign for what today we would call a hotspot, and a way of mobilizing white awareness about a Black threat. It's not at all used in deployment of an argument of, you know what, this is why segregation is a bad thing. We've hemmed in all these people, you know, fully, I think the Black population this time was probably about 10 or 13% population, and we hemmed them into a smaller percentage of the available urban land. You know, this is not sustainable on a public health level. That was not the message at all. When these maps start to travel around the country, it's used for a much different purpose. African Americans talk back to this, but in ways that are very much of a register of again, the way of doing uplift politics. And here is where the history of 100, 20 years ago or so is not the same as what we're seeing today. Today, in the era of the movement for Black Lives, well-organized and stable and established movements for queer and trans Black people, for movements I work in harm reduction. I've seen and studied movements for the rights of people who use drugs, people who are HIV positive. Those things couldn't have happened 100 years ago when we were doing respectability politics. Today, we're very much working against that. But today, that was the way you did politics, respectability politics. And so you had organizations like the Colored Law and Order League, a title which might make you cringe. It certainly makes me cringe, which said that, well, we have TB here, not because, yes, these poor Black people, don't know how to take care of themselves, or they don't know how to not spread the virus or the bacteria, but also because our white political structure has neglected them in their neighborhoods. And also, as you see in this map here, we've put vice dens in Black neighborhoods. And so this is a map of saloons, gambling dens, et cetera, which were by and large white owned and operated. So too were a lot of the slums. All right. This is where I think some of the historical lessons are more apparent for today. And I'm just gonna take a moment here because my air conditioner is loud and I turned it off so that it would not be picked up on tape, but now it's getting rather warm here. In the current moment, we're missing a lot of things. And one of those is that we're focusing on the short term and our reactions, and we haven't been thinking about what we did wrong before this happened. And I don't mean necessarily or solely the 2, 5, or even 10 years before this happened, but in a lot of ways, what we're seeing with this pandemic is the product of 40, 50 or more years of poor vision, of structural inequities that have actually grown worse since 1960, 1970, certainly since 1980. And we're paying for it in the toll of morbidity and mortality from literally a novel virus, something that was not around some recent years ago. And so this is where I want to talk about how that older history of tuberculosis actually in a lot of ways prefigures our blind spots today. All right, the road to Henryton, which is to say, I want to talk a bit about how we had a racialized response to TB. The short of it is that in response to this discovered, what people call the reservoir of infection in Black communities, the impetus was not to improve housing. Maybe a little bit, but that was not the real impetus of it. The real impetus of it was to surveil Black bodies, to have them tested, make sure they don't come in contact with white people, and then have them committed to sanatoria, where they would be essentially quarantined until they died. I know they were advertised as being places of treatment. They were supposed to be hospitals, but most state-run, which is say white-run sanatoria, there were some Black-run ones, but it's a very small number with a small number of beds. By and large, any of the blacks, the sanatoria which treated Black people were run by white people, and they only admitted people in very advanced condition. Basically, they were dead already, to be very just frank and colloquial about it. They had no hope of actually going into remission because they were too far gone. It was a way of essentially taking them out of the infection pool and protecting white employers and citizens from Black consumptives. Images such as this one were deployed in the effort of raising money to establish this, such as Henryton Sanatorium, which was established in Maryland, right outside Baltimore. The anti-TB movement became more focused on personal and state surveillance, and even more coercive, and even so more coercive surveillance, whereas Black politics verged towards more militant demands for the improvements of the fundamental causes of ill health, such as housing, such as wages, et cetera, et cetera. And here is where the two often did not meet in this resolution of creating these institutions. Here we see another slide with another ad, or not ad, a story talking about women leaving domestic ranks. This is also part of a gendered moral panic about women who are going to the workforce. Women who are not staying home with the children, but actually finding employment, which is very much part of the early 20th century political and social zeitgeist as well. This was a pamphlet also used in the service of raising money for a sanatorium to treat advanced stages consumptives, saying, our tuberculosis Negro, where is he now? Basically saying, do you know if your Black servant has TB, they're infecting you and the ones who you love, even as we speak. And what happened with Henryton Sanatorium, which was established in 1923 and 1924, is that by taking the most advanced cases, they really did nothing, very little for Black public health, first of all. It's really just a way of quarantining the very sick, but leaving many people who are sick as well around. It did nothing for the amelioration of the conditions that started all this in the first place. It did nothing for developing a intellectual or research dialogue to like what we would later call the fundamental determinants of health, social or structural determinants of health, health inequities, a literature that began to be named thus around the late 80s, early 1990s. So many of those were found as precursors in African-American research and some liberal whites in the early 20th century, but they did not get the voice that would have mitigated against this type of address. That changed a bit in the Depression New Deal, where the politics of want and necessity and labor organization showed that actually political economy does matter. And that's why we had the New Deal, for example, in which were embedded many health promotion activities. But at the same time, the New Deal gave us the codification and ossification of policies that were less formal and more local prior to that. I mean, I'm speaking principally of redlining, which began well before 1937, but were institutionalized in the Homeowners Loan Corporation and the Federal Housing Authority. You all probably should know about redlining. This is a map from Philadelphia's government redlining map. The areas that you see here are red are largely Black neighborhoods. Basically, red means, as it does in so many things, a danger zone. Banks would not loan, if you wanted to buy a house here, they would not give you the money. You couldn't get a mortgage for it. At the same time, Philadelphia had a widening income inequality, which we see on the left slide based on income levels in city and suburbs. Suburbs were increasingly white. You see people earning over $36,000 a year increasingly in the suburbs. Here we see it on the right-hand side explicitly by Black and white. The proportion of low income is largely Black, proportion of high income is largely white. So this here is not at all divorced from this here, is what I'm trying to say. Here we see other cities, again, a very pixelated and grainy table. I apologize for that. But some of the worst offenders in terms of segregation, which got worse actually between 1940 and 1990. We tend to think of segregation as being the vestige of slavery and maybe the vestige of Jim Crow. It actually got worse after the Civil Rights movement, the Civil Rights Acts. And so thinking, I promised I'd bring us back to how we think about our current moment. One is that there's a lot of ways in which this history ought to be useful, at least certainly how, and if not specifically the one I've offered, but certainly inquiries into this history and others should come into consideration in any of our policy discussions, in any of our advocacy in our organization. One is that it led, even though the period that I talked about was one largely of doing uplift and respectability politics, what we see in the post-World War II era was one that tended to be more likely to involve grassroots and more popular movements, particularly as we see with the Black Panther Party's health campaigns, such as those described by my good colleague and friend Alondra Nelson. The image here it comes from Robert Self's book, American Babylon, which I highly recommend as well. Alondra Nelson's book is called Body and Soul. I highly recommend that one for the students in the Mellon program and also anyone else who might be viewing this as well, because therein lies an interpretation of post-war Black political, one phase or one aspect of Black political health agitation. It also, I think it might do for us to think about COVID-19 in terms of a shorter history of environmental justice, which goes back in its early, you could say in a lot of ways, the movement that I described had some of the earliest iterations of what would later become environmental justice, but certainly those are more forceful by the 1960s. The phrase environmental justice shows up around, I believe, the late 1970s and the 1980s as a way of thinking about the environment and our health. That even though we've banished all infectious disease practically by 1970, at least the big ones, and we're certainly hopeful, we were talking about curing cancer in the 1970s. We're still talking about that. That's been very elusive. It turned out environmental justice showed that people are still getting ill and dying because of the built environment and the political economy of racial capital. And so then there's what I call a COVID Coda. We're still ignoring the structural here. We're ignoring this longer, 100+ years of Black body politics. In many ways, what we've witnessed with COVID-19's impact is a redux of what we saw prior to 1950, and particularly TB, but a bunch of other diseases too, and its political economy of racial capitalism. The profound and one would hope, inescapable conclusion that those of us occupying certain residential spaces, social positions, occupational trades, and political subjectivities are more vulnerable than others. It's something that you would think would have been obvious. I don't know about you all, but when the news first came out, I think it was like April or so, that, oh my goodness, Black and Latinx people are dying at 3 times the rate of white people. I think, many of us who are familiar with this history, and certainly the more recent history of the past 30 years, would have said, yeah, of course. Look at the predisposing factors. Those are ones that we've suffered for a long time. And this is a disease of space, literally a physical space. So why weren't you all prepared for this? How come your epidemiological models didn't take into account inequality when you were running all your mathematic algorithms and whatnot? And finally, in our politics about this, the emphasis on cure and treatment and hoped for eradication of the virus through either vaccination or herd immunity, and also our emphasis on individual responsibility, which is say masks and social distancing, come at the expense of relative neglect of structural inequality as the actual mediator of infection itself, of infection disease. And unfortunately for some 130,000 people, I think at this point, maybe 140,000, for them, death. On the right-hand side, I'm just giving you a quick schematic of the difference. On an individual focused and medicalized emphasis, we're going to talk about hospital treatment, right? But as we know in a lot of our communities, there were never enough hospital beds, even for the conditions that were endemic in 2019, let alone for a pandemic. And by the way, in a lot of those hospitals, if you show up there and you get admitted, you're probably really far gone. A lot of these hospitals were not and still aren't admitting people until they're really far gone. Those reports are from throughout the country. A structural critique would say there's a historic problem of lack of access to medical care of any sort. In a modern post-World War II era, post-Hill-Burton Act era, we think as hospitals as where you go when you're sick. We don't often think about are community health centers that are really good ways of developing or distributing healthcare if they're funded properly. We certainly don't think about what we should be doing to promote health so that people actually don't even develop disease. In an individual focused approach, we think about masks and social distancing. In a structural critique, we ask the question or recognize that many people can't social distance because of the jobs they do and where they live. And that should have been part of the discussion. We also say you should stay at home. What if you cannot afford to stay at home? What if you were living check to check in January 2020? You can't afford to do any worse than that in May of 2020, certainly. We think of, and so the structural critique would be, you know, part of our preparedness should be like, do we have a robust enough healthcare or welfare system rather, that when these things happen of any sort of economic crisis, it could be a pandemic, it could be a massive, you know, just fluctuation in a particular market, you know, a housing market, you know, just to take a wild example. You know, what is our look of preparedness then? You know, what's the state of our preparedness look like then? And speaking of preparedness, we talked a lot in the early pandemic about why weren't the masks and ventilators there, which is actually, you know, a very good question. And it's unconscionable that we just didn't. Masks are cheap to produce, you know, and we knew that a pandemic was probably coming. It was forecasted some years ago, in fact. It was really a matter of time, and we weren't ready for it. But I would also say that we need to think of preparedness in terms of more macroscopic and long-term planning, which would have in place an effective surveillance and testing plan and plan for pandemic-related economic dislocations. Keep in mind now that the testing that we are still doing, like roughly 5 months into this thing, is really more episodic. We're still really encouraging people, if you think you have symptoms, get tested. That's not surveillance. Surveillance is more, let's see if we can test as many people as possible and see how the averages work out. And that way we'll have a sense of where the epidemics are. We're in a pandemic, but a pandemic is nothing but a lot of either national, state, or local, or even neighborhood epidemics. And we have really very little way of tracing the epidemics because we're not doing very good surveillance. This is a problem because it's just going to keep spouting up all over and surprising us until we have a better way. We're like a submarine without a periscope, or, you know, without any sort of way of seeing what's ahead of us. So I would like to think, I certainly hope that for viewers here, that this history might offer a way of thinking about our contemporary moment. And when you think about your participation in future political, social, economic, professional organization, that you think about some of this as well. Thank you so much. Look forward to the Q&A.
Well, thank you so much, Sam. That was brilliant. And I love that you brought the history of TB and turn of the century racial politics to bear on the present. I think that that's something that we're all really looking for, that grounding right now. And I certainly want to invite everybody to submit their questions through Q&A. Rick Mizell, who led our second session, and Gigi Pierre, who have joined us. Gigi was one of our Mellon scholars, are on as panelists. So I invite you both to join the conversation and raise questions as they've come to you. I want to start with like a really simple question, because I probably know the least about the history of public health than anyone in this seminar. But, you know, like when I'm thinking about where I look for expertise today, I turn to national entities like the CDC or international entities like WHO. And, you know, when you were talking about sort of how reporting legislation got started really at a very sort of local level with Baltimore, the Baltimore reporting level, I'm curious to know then, you know, pre-New Deal, pre-large federal government that's intervening in all sorts of complicated and often counterproductive ways, where are the power centers of public health at the turn of the century?
Wow, that's a great question. Thank you. Well, there's this larger movement for public health, which is firmly based in, I'm hesitating because it's based in the progressive moment, the progressive era, but it's also one of the things that contributes to the progressive era. Mm-hmm. So one of the kind of philosophical founding tenets of, you know, turn of the century progressivism is more or less a faith in quote unquote science. All right. And that is something that privileges the bacteriological revolution. It privileges the microscope and what we can find there. It privileges the organization, often hierarchically, of state, like a muscular state apparatus to fight disease, through rational management of people and talent. These are things which I think a lot of us who are supportive of science, I mean, after all, if you believe in climate change, right? And you see someone who adamantly does not, if depending on how informed the conversation is, you might say, hey, what, you don't believe in science? Like it's basically a way of saying like you're not really that intelligent, like the science is in on this one. So certainly science is something that we, in the abstract, is something that we attribute to a kind of progressive mood here. But what I point out in terms of that paradox is that people often forget that the eugenics movement was based in science. It was literally a movement to rationalize society by cleaning up the people who are defective. Its most pernicious, ugly, murderous, and nihilistic version, of course, is what we saw in Europe in the 1930s and into the 40s. But it's practiced in, perhaps less malignant and widespread ways in the United States and in the UK. And certainly motivates a lot of, European colonization in Africa as well, like these beliefs. These are movements that you wouldn't have had 100 years ago. Certainly you had racism 100 years before that, but eugenics comes at the progressive moment. So that's to say that when we say that the public health movement, with its privilege of, we need statistics. Microscopes show us where the bacteria is. If we can do good contact tracing, we can help people, get treatment and not spread to the people they love. Those are all things I think a lot of us would sign up for. But we have to be very careful because the back of that can often be coercive, racist measures as well. Science is not, I know there's a lot of people who are, quote unquote, pro-science, but in the abstract, science is just, it's an activity of human endeavor. And it can do a lot of bad things as well. We've done a lot of bad things in the name of science. And I don't even think it does well for us to make a difference between good science and bad science. The latter meaning, it's just faulty assumptions and faulty conclusions, bad information, garbage in, garbage out. Sometimes like the numbers are all there, but your entire purpose of doing this is ethically suspect. So that's the broader, I think this is a longer winded way of answering what was a great question. But I'm not doing well with shortening it, which is to say that the public health movement is very much one of rooted in progressive in the capital P sense, but also I might even say the lowercase p sense. I find that interesting and its shortcomings because, if you are a dyed-in-the-wool racist, or like a eugenicist, someone who believed that the black population would become extinct, they actually weren't that numerous in public health. Many people in public health said, you know what, like they probably did believe, a lot of them actually did believe, and vocally said so, in racial inferiority. But they still kind of based it on a belief of we think of everything as an organic whole, which is also part of the progressive idea. Like the Chicago School of Sociology is born from inspiration from 19th century ecological studies of everything, all systems being united. So if you're working in public health at this time, the idea that you just let Black people die because they're racially inferior actually doesn't get the mission done. What gets the mission done is you remove all the Black cases and let them die in quarantine, perhaps. But you don't just neglect them and say, survival of the fittest, because they said, no, while they're dying out, they're going to take a lot of us, meaning white people, out with us. And I do think that there's a lot of ways in which liberal thought today does the same thing. When we treat people who are vulnerable as needing only our compassion, but not seeing them as viable political subjects, not subjects like subjects to a king or a regent, but subjects, they have their own subjectivity that needs to have an air in a public commons, then we're doing the patronizing and condescending racial liberalism that we saw 100 odd years ago. When we say, for example, take something completely unrelated, that, you know, mass incarceration is bad because it's so inhumane. Well, yeah, it is. But it also has damaged our political system so well. Think of all the close elections in like Florida in the year 2000, which had one of the largest rates of voter disenfranchisement for people with a criminal record, people who had served their time, but could not vote, walking free amongst us, who couldn't vote, and a lot of them couldn't get jobs or couldn't get housing. So we've socially immobilized a lot of our people there. This isn't about pity or empathy or compassion. It begins there, but it also is about power, that all these things are put in place for the maintenance of various regimes of white supremacy. And that's where I think, I don't have time to critique Donald Trump, you know, I mean, like the jury's in on that one. But I do worry about some of our liberal friends who don't seem to get it either. I think I answered about maybe 40% of your question, Will. Hopefully, we'd circle back around to some other ones. It's a great question, and I think it'll probably animate some of the ones as well, or show up in different ways. So
well, and I'm delighted with the 40% that's answered there. Rick and Gigi, you've attended previous sessions. I mean, Rick, you led one. Gigi, you've been an active participant in all of them. Are there any connections that you want to try to think about drawing out across the sessions? You're welcome to jump in, or I can give you some time to mull it over too, and jump over to an audience question.
I think there are so many like connections. Like personally for me, both of your presentations intertwine with each other so well. You know, Dr. Mizell was discussing, you know, diabetes and the lack of like of like, oh my God, I'm trying to choose my words, but the lack of agency that Black people had over their own disease. And when we were talking about tuberculosis, and how, you know, like basically with the photograph of the women basically just like not even knowing what they're posing for or anything, I just like, just the lack of control that Black people just have, you know, like over just basically just living, is like, I just thought that just meshed so well with both of your presentations, because like it's true, like there's like you're blamed for being sick, but you don't know what to do about it. Like, so it's like there's no win. That's what I thought about it. I'm sorry if my words are like so jumbled.
No, I get, and I thank you for that. Thank you so much, Gigi. And you know, I would also say that we have to be really careful. I mean, that photograph was, you know, I don't know who took it, but I mean, the article was written by a white woman. It aired, or it ran in a magazine that was certainly directed towards white people and probably largely read by white people. The photographer was probably a white person. And certainly the use of that image were for purposes of a white political agenda. But I'm equally critical, and this talk is from a book that I published years ago on this topic. And in that book, you'll see that I'm equally critical of Black political leadership that does, you know, what Evelyn Brooks Higginbotham called, you know, politics of respectability. It's a lot of violence could be done in that name as well. You got to be really careful. What's the old phrase? They may be our color, but not our kind, or something, or, you know, like people, you know, there's a way of doing representational politics that happened, I mean, still happens, particularly in electoral politics, where, you know, we want to support the first Black mayor or the first Black whatever, or so and so, but we need to hold them as accountable as we would hold white people as well, because they're in positions of power and also in positions of compromise as well. So yeah, we have to be very careful about that. And thank you for the comment too, and thank you for joining us.
I'll defer to the Q&A, but I'll just say quickly, and I apologize. I didn't realize I was going to be on live for my T-shirt. But I made the point 2 weeks ago that diabetes really was about American history. It was about the progressive era. It was about New Deal. It was about the Civil Rights era, Black Power. It was about all of these things that we sort of think of as 20th century history. Diabetes narrates 20th century history. And I think tuberculosis does as well. And all of these diseases in their own way sort of help us to frame the historical past. And one thing I loved about Sam's talk today is his theorization of the Great Migration, which is remarkably under-theorized as a form of health politics, and how he conceptualizes that, I think, is quite brilliant in terms of why people migrated, the rationale for migration, but the influence that they had, those migrants, on public policy in different cities across the country.
Coming from you, Dr. Mazel, that is the highest praise I can hope for. We are recording this, right, Will? We're recording this? I think that might be my voicemail greeting on my phone right now. What was that you just said, Rick? Yeah, that might be next time somebody calls me, they're going to hear your voice, that description. I appreciate it, and especially knowing your work as well. I'm over here sweating, partly because it's hot, but also because I am cognizant that I had to speak after Rick, what was it, a week or two ago? So yeah, it's a tough act to follow. And having read your first book and some of the work that you're doing, working towards this next one, I do appreciate that. And I think the way you've been thinking about, particularly environment, in the first book, has been certainly field changing for a lot of us and influential for. I think you and I met as I was finishing this book a while ago, and I think your fingerprints are probably in some of these chapters as well. When we were, first met, many years ago. What you said about how diseases narrate history and politics, I think, is really something I've been trying to get my hands around, and I think there's ways in which, right, like health is about the body, right? In ways that it is and is not, right? In a lot of ways, it's abstracted. It becomes a metaphor for bodies, a metaphor for politics, a metaphor for peoples, for races, things that we imagine as races, et cetera, et cetera. But certainly in a very real, visceral sense, it's about bodies. And so it seems almost natural. Okay, scratch that. This will be a take 2 on this one, because a good historian of science should never talk about what's patently natural, because everything is constructed, right? But certainly it's not unexpected that how we think about our bodies would also have a lot of overlap and would also greatly inform how we think about literally our body politic, right? But then there's ways in which that's not limiting, because it could also be liberating in some ways, but also ways in which it can hamstring some of our politics. When you are always starting from a position of being biologically inferior, and then you live in conditions of truncated health hopes, there still hasn't been a period where, Black people approach the expected life expectancy of white people, right? Like, it's just never happened. Hopefully one day it will, but it won't. And then, when you live under that kind of weight, it does things to how you think about politics as well. It makes it more urgent. I certainly think that's what we saw in the early 20th century, and that's how we got politics of respectability, right? It would not do for people saying, I don't trust your tuberculosis regime here. It looks to me like you want to just lock me up and throw away the key. That is not a sentiment that's going to make its way very often to that political moment where we're actually privileging the voices of working class Black people. I mean, when you think about how long it took in the HIV/AIDS movement for people of color to be able to lead some of these HIV organizations. Like HIV became very quickly corporatized. Like I forget who it was that called it the AIDS industry, like in the 90s. And then you had people of color who were HIV positive, who, you know, for many, many years were existing in the shadow of these organizations. You know, these organizations that would not talk about the racial political economy of transmission, that would not talk about sex work, that would not talk about drug addiction, but really just took it for granted that HIV was about gay white men. You know, we're always kind of caught behind that 8 ball, so to speak. And it is a way that we narrate it, but it often it also becomes a way in which we get narrated. Like in that image, those women had no control over that image whatsoever. That was someone else narrating them. So yeah, I would think Rick and I do this a lot, where we just start thinking out loud to each other, and, you know, just, so yeah, that's what pretty much I was doing there. And thanks a lot, Rick. I appreciate the comments, and thanks for being here.
We have a couple of interesting questions. One that sort of takes us back to the present immediately. Taylor Robinson asks, what is your belief on why across the US, states aren't reporting cases by race? Does this lack of prioritization of race indicate a clear lack of prioritization of health disparities?
Yeah, that's the short answer. Absolutely. Yeah. No, they didn't care. They weren't concerned. I know less about this than I would like to, and certainly there's people who are more expert. But from my understanding is that the CDC has had a pretty toxic culture for many years. And toxic culture is not something I use, it's not a phrase I use lightly. I use it now because, as I recall it, that is exactly the wording used in an open letter signed by over 1,000 employees of the CDC, which was leaked to, I want to say, the Washington Post, or was it? No, I think it was NPR, actually. This letter was sent on the 30th of June to the higher ups, to the head of the CDC and people below him. And it got leaked. I guess there was no response. So finally someone leaked it to the press, and they called it a toxic culture. People will say that, oh, this is a novel virus that showed up out of nowhere and we were caught off guard. The virus itself is, yes, novel, but we certainly knew that one was coming. We had SARS, we had MERS, we had H1N1, which isn't a coronavirus, but it is a flu virus transmitted in very similar ways. We knew that this is what the 21st century is going to be about, and we weren't prepared. We also knew that health disparities had been a problem as long as we've been studying them as health disparities or health inequities since the 1980s and 90s. We should have been prepared for this, but the CDC has been apparently neglecting it. And that's why we didn't have the racial data there. And we still don't really. I mean, a lot of that data is about numbers, right? It's not the type of geographic data we might want to know. Because then we could send in teams to really study what's going on. If we knew, yeah, Black people in Cincinnati are dying at these rates here, and white people are. But let's go below that and think about, okay, well, these Black people who are dying so at such higher rates, where are they living, and what does that tell us about transmission? Unless you're just satisfied to say, yeah, Black people die more of COVID-19, then you haven't really answered the question. Do you see what I'm saying? Yeah. So the short answer to the question is yes, absolutely, yes.
We have a sophisticated question here from Veronica Watson. She writes, I appreciate your reading of individual versus structural approaches to reading COVID. I'm wondering, though, if there's a way of reading the individual-focused approach of responding to COVID as part of the neoliberal framing of public life. Isn't most of how we think and what we do related to public life rolled out in terms of an insistent individualism or individual responsibility? If that's more or less true, how do we really ever get to the kind of structural analysis you're offering?
It's not more or less true. It is more true. It is that's an excellent question. It is absolutely true. And that is part of the health regime under which we've been living, you know, you could say some of its roots go back to the 1950s and 60s, where we started to talk about diseases of lifestyle. But then also certainly since the 1980s and 1990s. And certainly the 21st century began with that neoliberal emphasis on health in a lot of ways, right? As I said, my slide that posed individual versus structural was basically a nod to Taylor was the questioner's name. What Taylor alluded to as neoliberalism, absolutely. One of the several tenets, I think there's like 4 central tenets to neoliberalism. One of them is that you shift the onus of responsibility to the individual, not to the collective, not to government, which is an entity to which we all belong, in which we all have membership, and which all have stake and should all have a voice. You shifted the onus of that to individuals. Yeah, and it's certainly, you know, telling people mask up and do social distance is important. I'm certainly not an anti-masker. You keep those people away from me for a number of reasons. One of which I don't want to catch what they have, but also I find them a little bit odd, to be honest with you. But I'm also very concerned about when that's like the kind of end, when the focus of COVID control is social distance, and we're working really hard on this vaccine. Because if that takes another 12 months to get the vaccine, that's, you know, 18 months total that we've labored under this thing, where a lot of people die. And then what happens when COVID, you know, I don't want to be a downer here, but what happens when COVID 2024 shows up? Are we going to keep doing this Groundhog Day thing over and over again when we know that the mediator of infection, disease, and death is largely those structural things? Neoliberalism, another tenet, is the idea that you can shrink government and that let individuals do what they think is best for them, which is, you know, virtually impossible in a real world where people are always, the actions and options. And if you want to get down to a discussion of political subjectivity, even how they view their options and conceive of their options are always dictated by other things that are more suprastructural, such as capital, but also a whole host of other things. So yeah, this is part of it. Until we have a discussion about, you know, our preparedness needs to be, how do we allow 30% of our population to at least survive without going to work? We'll still be engaging in neoliberal politics of health. And I say that not just in the context of COVID-19. What happens when we just have another housing, you know, the housing bubble isn't that long ago. It's like, what, 13 years ago? Who knows what the next bubble is going to be? It might be student loans. Who knows? But when we have larger numbers of people thrown out of work, part of our preparedness needs to be, we got you. You know, like unemployment is actually pretty robust. Neoliberalism did the public or the personal responsibility, I always forget the name of the act, but the act that Bill Clinton signed that ended welfare as we know it in the mid-1990s, and just put the responsibility of your subsistence on you, even though the markets were in crazy fluctuation and have been since 1973. So absolutely, that's part of it. Yeah.
And I apologize, that was Veronica Watson that posed that last excellent question.
Okay, thank you, Veronica.
I'd like to close this out because I know that we're coming up on 7 o'clock, which means you have been deprived of air conditioning in a New York City apartment in July. I can only imagine what you're going through.
I think I've just hit the level of delirium at this point. I don't even notice it at this point. Yeah, so I should probably hydrate soon though before I pass out.
Absolutely. And so I'd really like to give the last word to Susan Eagle, who has this lovely summative comment where she writes, not so much a question, but a sincere thank you. This whole series has been incredibly informative, and I'm planning substantial revisions to all of my fall public health courses. We've got a lot to recognize and reckon with. So with that, I'd like to echo that and say
we've got that recorded as well from my voicemail.
Oh yeah,
message.
Yeah.
Okay, all right.
Yeah.
I got okay.
That can be your next voicemail.
I'm gonna have them both. I'll do them both on there. Yeah. So, thank you, Susan Regal. What's the name?
Susan Eagle.
Eagle, I'm sorry. Thank you so much for that. And please feel free, if you're teaching courses, I would love to hear about them. So please feel free to find me. We can talk one-on-one via email or whatever as well. So thank you for that comment and for the appreciation. I really enjoyed being here as well. I'm a big fan of this program. It's been a pleasure working with you, Will, and the staff. It's been a pleasure meeting the fellows. It was Dee Dee who brought me, I'm sorry, Deirdre Cooper Owens who brought me here. And she's someone whose work I've respected for a number of years. And so it's a real honor to have joined you. And thank you so much. I would have done it with twice the heat.
Well, thank you so much. And I know there's been some interest in different, follow-up notes. So I might follow up with you, Sam, about a couple of the books that you mentioned in the course of your talk, because I know that there was some interest in potentially looking them up. And yeah,
absolutely.
So
yes.
Within the next week, I'll be following up with all of you by email, inviting you to fill out a short survey about our seminar so that we can continue to improve upon these types of things, but also with a link to this final recording, which will be up on YouTube, and some notes. So thank you all for participating on this very warm July evening. It's been an absolute privilege learning from all of you.
Likewise. Happy to be here. Thank you so much. Take care, everybody.
Godspeed.